So typical pneumonia, the three main bugs need to know: strep pneumo, H flu, Moraxella. Atypical, mycoplasma, chlamydia, and legionella. Hospital acquired or nosocomial acquired are E. coli, Pseudomonas, and Staph aureus. Remember, typical lobar consolidation, atypical interstitial infiltrates, and hospital, especially if it's mechanical ventilation, this can predispose to aspiration pneumonia, which will usually be in the right lower lobe, and you might see some air fluid levels that indicate abscess formation. Famous antibiotics, you need to know the difference between, for pneumonia, outpatient versus inpatient. So outpatient, if it's typical pneumonia, amoxicillin. If it's atypical pneumonia, azithromycin. Inpatient, most common will be a fluoroquinolone. Aspiration pneumonia, then it'll most likely be clindamycin to cover for anaerobes. And then if it's hospital-acquired pneumonia, you want to cover for Pseudomonas. So this is, you want to use Zosyn, which is piperacillin tazobactam, or cefepime, which also covers Pseudomonas. So the Ppd skin test. A positive test, it really just depends on the demographic you're part of. A healthy person, 15 millimeters or more is positive. For 10 millimeters or more, it's positive if you are someone who's been incarcerated, or if you're a healthcare worker, or if you're a foreigner. If it's greater than 5 millimeters, it's positive if you have HIV, or if you've been in close contact with someone who's known to have TB. If the PPD test, the wheel, is positive, depending on what group you're in, say I'm a medical student or a physician and my wheel is 11 millimeters, that's positive. What's the next step? The next step is a chest x-ray. So the chest x-ray can either be positive findings or it can be clear. If it's positive findings, then you're gonna see a bunch of stuff in the upper lobes, cavitations. I'll probably also have symptoms such as fever, night sweats, weight loss, hemoptysis. If it's positive, then I will be treated with the right regimen, which is rifampin, isoniazid. Make sure to give B6 with it. Why? Because if I don't give B6 with isoniazid, it can cause neuropathies. And then P is pyrazinamide and E is ethambutol. You're gonna give the 4 of those for 2 months, and then after 2 months, you're gonna give rifampin and isoniazid for additional 4 months. But then if it's a negative chest x-ray and it's clear, then you treat with isoniazid for 9 months. Someone might ask, hey, but what if I got the BCG vaccine? Well, it doesn't matter. If you've gotten the BCG vaccine and you have a positive wheel, you still do a chest x-ray. If the chest x-ray is negative, you still do isoniazid for 9 months. All TB meds can cause hepatotoxicity. You stop only if the LFTs are greater than 3 times normal. Pyrazinamide, classic side effect is it can cause gout, and ethambutol, the classic side effect is it can cause eye problems. Rifampin can cause the orange sweat and orange tears, which can look like blood, and isoniazid can cause neuropathies and hepatitis. So next is meningitis. Meningitis, you have to know about the ages. Less than 3 months, everybody in between, and greater than 50 years old. So the general population, the most common are strep pneumo, H flu, and Neisseria meningitis. Neisseria meningitis will cause a rash as well. If they're less than 3 months old, you have to consider a different set of bugs, which is group B strep, E. coli, and Listeria. It spells out Bell. And then those kids who have So you want to treat meningitis empirically, right? So because the cultures can take a while to come back and the effects can be devastating, so you want to start treatment as soon as possible. For your normal population, which is strep, pneumo, H flu, and Neisseria, then you want to treat empirically with vancomycin and ceftriaxone. Vancomycin will cover the strep, and ceftriaxone will cover the Neisseria. But then if it's less than 3 months old, you want to cover for listeria, so you want to add ampicillin. And this happens as well for adults who are greater than 50 or immunocompromised. You also want to add ampicillin. Remember, meningitis presents with headache, fever, nuchal rigidity, photophobia, and it will also have the Brudzinski sign, which is when you flex the neck, it can cause hip flexion to reduce tension in the spinal cord. And then remember that the Csf findings, right? So you can have viral, something that indicates viral, something that indicates bacterial, or something that indicates fungal. Fungal is usually more immunocompromised, like AIDS patients, and that will be more like Cryptococcus neoformans, which will have the India ink positive stain, and that's treated with amphotericin. But my point is, you need to know the CSF markers. All of them will have increased WBCs, and most of them will have increased protein. But the key here is look at what type of WBCs are elevated, and is the glucose low or normal. So bacterial, neutrophil predominant, glucose is low. Why? Bacteria consumes glucose. Viral is the lymphocyte predominant, glucose is normal. Viruses don't consume glucose. Fungal, kind of in between both. Lymphocyte predominant with decreased glucose. And then the most common viral meningitises are herpes, echovirus, or enterovirus. One exception is TB, although a bacteria can look like a fungus. But then TB will have the basilar enhancement. And another key thing is herpes will tend to go after the temporal lobes and have seizures, and the lumbar puncture will also have blood. A UTI is usually treated empirically without a urinalysis, and the treatments are, the first line treatments are TMP-SMX, nitrofurantoin, and fluoroquinolones. If they're pregnant, then you want to treat with a different set of antibiotics. Nitrofurantoin works as well, but you can also use amoxicillin or cephalosporins. Sometimes there's something called a complicated UTI, and in that case, you want to do a urine culture, and that happens in 4 demographics. One is diabetics with the UTI, the second is pregnant people, the third is a male with a UTI, and the fourth is an immunosuppressed patient. If someone has greater than 2 UTIs per year, that's not good, so you want to give them TMP-SMX prophylaxis. And also, they can either take it prophylactically every day, or they can take it as a post-coital prophylaxis. Again, prostatitis, epididymitis, or orchitis depends on the age. If it's young, most likely gonorrhea and chlamydia. If it's old, most likely E. coli. So the young patients treat with ceftriaxone, azithromycin. The old people treat with fluoroquinolones. HIV, you do a C-section if the viral load is greater than 1,000. If it's below that, it's fine, you can deliver vaginally. Remember, HIV, contraindication to breastfeeding. The prodrome, very similar to mono, sore throat, malaise, fever, lymphadenopathy, but the kicker is they'll have a rash, possibly diarrhea. And then remember, prophylaxis starts at CD4 200 or less, TMP-SMX, which prevents Pneumocystis jirovecii. Once the CD4 drops to below 50, then you prophylax with azithromycin, which covers for Mycobacterium avian complex, which causes fever, diarrhea, and weight loss. Another complication of AIDS or HIV is Cryptococcus meningitis, which is treated with amphotericin, and it's associated with pigeon exposure. And then CMV can cause colitis, esophagitis, retinitis, and bloody diarrhea. So AIDS, think of 3 types of diarrhea: cryptosporidium, CMV, and MAC. Cryptosporidium will be a lot of watery diarrhea, whereas CMV will be bloody diarrhea, and then MAC will be fever plus diarrhea. People with HIV get 3 vaccines: pneumovax, influenza, and Hep B. You should know the difference between lymphogranuloma venereum, which is a type of chlamydia, L1 to L3, versus granuloma inguinale. They both have genital ulcers plus inguinal lymphadenopathy, but lymphogranuloma venereum has the buboes, so big, painful, hard, red inguinal nodes, whereas granuloma inguinale, the nodes actually ulcerate and turn into granulomas. And then they both are painless ulcers. Remember, the painful genital ulcers will be either HSV or chancroid, which is Haemophilus ducreyi. Primary syphilis first starts with this painless chancre, right? Then secondary palms, rash on the palms, plus the condyloma lata over the genitals. Then you can have the late phase, which presents with gummas, which are granulomas, tabes dorsalis, which affects the dorsal columns exclusively, and syphilic aortitis, and also meningitis. Common bugs, cellulitis, most likely Strep Pyogenes. Erysipelas, also Strep Pyogenes. The difference between the two, erysipelas has a rapid onset, whereas cellulitis is more gradual. Erysipelas also has clear distinct borders, whereas cellulitis does not. And then an abscess, you want to think about Staph aureus. And then necrotizing fasciitis, the two common ones are Strep Pyogenes or Clostridium perfringens. They both have pain out of proportion. So it'll be erythematous and red. It advances pretty quickly, but when you barely touch it, they'll be screaming in pain. And then the difference between the two, the most common is Strep Pyogenes, but if there are gas bubbles or gas gangrene, then it's Clostridium perfringens. So for the tetanus algorithm, the things I want you to think about is ask yourself, greater than 3 vaccines or less than 3 vaccines in their life? Clean wound or dirty wound? So first, if they've had greater than 3 vaccines in their life, if it's clean, so clean means, superficial, no dirt in it, not very deep. If it's been greater than 10 years since their last booster, give the vaccine. Other than that, leave it alone. If it's a dirty wound, so like deep or dirty, then if it's been greater than 5 years, then only do give the vaccine. For people who have had less than 3 tetanus vaccines their whole life, or their vaccination status is unknown, first, is it clean or is it dirty? If it's clean, then you give the vaccine only. If it's dirty, then you give the vaccine and antibody. And that's basically it for tetanus. If they have tetany, you can add diazepam to minimize the muscle spasms. Septic arthritis and osteomyelitis, you should know the common bugs, and they're the same for both groups, luckily. So the normal person, it'll be Staph aureus, but the person who has sickle cell, it'll be Salmonella, and the IV drug user will be Pseudomonas. Remember, any swollen, painful, red joint, the next best step is to aspirate or do arthrocentesis for analysis, because we fear septic arthritis. Signs of septic arthritis would be fever, leukocytosis, and inability to bear weight on the joint or move it at all. That's a sign of septic arthritis. Usually the aspiration will show greater than 50,000 white blood cells. So Lyme disease, remember, starts with the target rash called erythema migrans. The first thing you want to do is determine what kind of treatment you want to treat with. And if it's person older than 8 years old, then doxycycline. But the trick question they love to ask is a kid with Lyme disease less than 8 years old, so a 6-year-old with erythema migrans, what's the treatment? A, doxycycline, or B, amoxicillin? It's B, amoxicillin. Why? Because doxycycline is a tetracycline, and tetracyclines can cause teeth discoloration, which isn't good for a little kid. And then malaria, you have 3 flavors: Plasmodium falciparum, Plasmodium vivax and ovale, or Plasmodium malariae. And and to know which one is which depends on the timing of the fevers. So falciparum has a constant fever, vivax ovale has a fever every 2 days, and malariae has a fever every 3 days. So any vignette where the patient has cyclic fevers, think of malaria. Also in the vignette, they'll have recent travel to a country such as India or a continent such as Africa. The treatment generally is mefloquine But for Vivax and Ovale, you want to add Primaquine 2, which will kill the hypnozoites in the liver. Treatment of rabies is irrigate the wound, plus give antibodies, plus the vaccine. And remember, it presents with hydrophobia and encephalopathy, and they will be really afraid to drink water. The problem is, at that stage, it's too late and most likely fatal. And rabies is most often caused by exposures to bats and getting bitten by a bat. Cat scratch disease is caused by Bartonella henselae. The classic presentation is a distal cat scratch with a proximal lymphadenitis, and you treat this with macrolide or doxycycline. Aspergillus, 3 flavors: ABPA, allergic bronchopulmonary aspergillus, aspergilloma, or invasive aspergillus. So allergic bronchopulmonary aspergillus, think of asthma and eosinophilia. The aspergilloma, think of hemoptysis with a chronic cough. On chest x-ray, there's a fungus ball in the upper lobe. Invasive aspergillus, very systemic, so fever, leukocytosis, hemoptysis with the classic halo sign, which is pulmonary nodule with a surrounding ground glass opacity, and this is treated with amphotericin. Dimorphic fungi, the mnemonic His-Cock blast spores, so histoplasma, coccidioides, blastomyces, and sporothrix. So histoplasma associated with bats and caves. This one, I want you to remember bilateral hilar adenopathy. A lot of these dimorphic fungi can have presentations that can be confusing. It can seem like almost like TB with the fever, night sweats, weight loss, and possible hemoptysis. But the kicker here is you should be suspicious that they're trying to get at a dimorphic fungi, because they'll usually talk about locations. Like for example, blastomyces is called Chicago disease. So you'll see a person who's from the Midwest. They'll mention specifically someone who's from like Iowa or Illinois. And then versus coccidioides is more like on the West Coast. So like someone from like Arizona or California. So look for location. And then blastomyces, I want you to remember purple skin lesions with pneumonia. That's blastomyces plus Midwest. Coccidioides, West Coast with respiratory symptoms and unilateral hilar adenopathy. Sporothrix, this is the person who gets their hand cut by a thorn, and then they have the lymphadenitis that follows a trail up their arm, and then this is treated with itraconazole or potassium iodide, or you can just watch Sketchy Micro. Cryptosporidium, this is HIV with severe watery diarrhea. So the hookworms, you have, spells out sand, strongyloides, ancylostoma, necator. These all go in through your feet, goes up to your lungs, you cough it out, and then you swallow it. It ends up in your GI system. The thing about these parasites and worms is look for eosinophilia, because worms, parasites, anything foreign like that, the eosinophils go up because they have a weapon called major basic protein, which helps lice, worms, and parasites. Enterobius vermicularis, remember the anal worms on a young kid. Scotch tape test shows a lot of baby worms, and you treat with mebendazole. Tapeworm, think about food sources. T. solium is from pork, D. latum is from fish, and T. saginae is from beef. You want to treat this with praziquantel. Schistosoma, this is the snail. Think of a person from the Middle East who has hematuria with eosinophilia. Toxic shock syndrome, think shock plus someone who has had a nosebleed and has kept some sort of paper up their nose for a while, or tampon that has been in there for a while. And then this person will have desquamation as well. The Staph aureus exotoxin is hyperactivating the T cells, which release a lot of cytokines, which causes you to go into shock. So treat with IV fluids and vancomycin. Neutropenia is an absolute neutrophil count of less than 1,500. High yield to no neutropenic fever is you treat empirically, and that it's the culprit is Pseudomonas until proven otherwise. So you want to treat with Zosyn which would cover Pseudomonas, and Zosyn is the brand name for piperacillin tazobactam, but it's easier just to say Zosyn. Gastroenteritis can be bloody or watery. The most common watery ones are rotavirus, norovirus, or E-tech if they had recent travel to somewhere like South America. But the bloody ones can be Campylobacter, EHEC, Salmonella, Shigella, and Yersinia. Those are the common ones. They will be febrile and have bloody diarrhea. And the question is, what's the best next step? And the best next step is stool analysis for white blood cells. What if the white blood cells come back as positive? Then the next best step is stool culture. Most bloody diarrheas are treated symptomatically. You only give antibiotics if they're really young, really old, or immunosuppressed. A definite no-no is don't give antibiotics for EHEC, which predisposes to hemolytic uremic syndrome. Someone who takes antibiotics and then develops diarrhea afterwards, think C. diff. Best next step is C. diff toxin.